I'm presenting today at ASCO the results of the INO-VATE trial, Inotuzumab trial by age of the patients. In fact, Inotuzumab ozogamicin, it's a monoclonal antibody that targets CD22, and it's conjugated to calicium-mycin, a toxin. So when a drug is bound to the CD22 at the surface of the cells, it's internalized, and then the calicium-mycin is delivered that causes double DNA breakage and then death of the cells. That is how it works. We assessed the drug in leukemias in a phase 2 study where we tried to schedule 1.8 milligram per meter square monthly and then 1.8 total dose, but given in multiple divided dose, 0.8, 0.5, 0.5 weekly. Overall, in refractory patients, we found 50% responses, although the weekly regimen was found to be safer with less complication, mainly VOD and liver disturbance. That led investigators, among them ourselves at MD Anderson, to take this drug into a randomized trial called INO-VATE trial, where patients were in salvage 1 or 2 were randomized to either standard of care, mostly received either rubicin or Inotuzumab on a weekly schedule. The primary endpoint was composite response rate and overall survival. We do not know the survival data yet. It will be presented at the EHA meeting in Denmark. We know for the responses, overall 80% responses. And then among the responders, they had an even deeper response, what we called MRD negativity. Now, as you know, the goal in ALL, when you relapse, you go for transplantation. Although that may not be the best approach for everybody, especially if you failed multiple agents, transplant will not lead to great outcome. So the concern as well, is it toxic in young people or elderly people? And the purpose of my presentation was to assess by age, and we found that age doesn't matter. The drug was equally effective and equally safe among the group of patients, the younger and the older patients. Now, one should be very careful. The drug can cause, in a small subset, veno-occlusive disease or liver damage. One should be very careful. And somebody who failed already transplant, or try not to give a drug that can cause to hepatotoxicities. I think it's a very manageable drug, quite safe and quite effective, and I look forward for the future to use it earlier than later in salvage 1 instead of waiting until multiple salvage. Why? Because my duration of response will not be as long as durable. One. Second, I may take a risk of more safety concern. So therefore, I will jeopardize on efficacy and safety. Therefore, my message is to use Inotuzumab on a weekly dosage early on at the first salvage. Ongoing trials are assessing combination of Inotuzumab with chemotherapy. We have what we call the hyper-CVD Inotuzumab. We have a better responses, and we have a better, compared to single agent, longer responses and better survival. I see the future of combining, to use early on in the front line, not the relapse, in order to improve the cure rate and improve survival. I assess in MRD setting as well, because less disease you have, earlier the drug, better is your outcome. And finally, exploring different schedule, lower dose schedule to minimize safety while not compromising efficacy. Thank you.